All right, fulfilling some requests. I had a lot of requests for a talk on heart failure. Full disclosure, I am a trauma surgeon. I'm not a cardiologist or an interventional cardiologist or any of the above or an electrophysiologist, but we could talk about this. So for my fellow EM hospitalists, our critical care people, I want to start off with an important concept from a documentation standpoint. So whenever you document heart failure, you need to specify whether this is acute versus chronic, okay? And whether this is systolic versus diastolic. And a caveat to that is heart failure. And a caveat to that is it can be literally all of the above, okay? It could be acute on chronic, systolic, and diastolic, if it truly is. So let's iron this out a little bit. So how do we measure the function of the heart, right? So we get a transthoracic echo most of the time, a TEE, an echocardiogram, and that's going to give me an ejection fraction. And then what's the more invasive role here, or one? So that's a transesophageal echocardiogram. So that's a little more invasive, and I've seen esophageal perforations from this exact procedure. So like I said earlier, literally anything and everything you do carries inherent insane risk. So just always keep that in the back of your mind, just as I said, putting in a peripheral IV does. So we get an ejection fraction. So a good one is like roughly 60%, okay? So that's gonna give us an idea of the systolic function of the heart. And then on an echo too, we get this reading of like of the diastolic dysfunction as well, and they grade it. So a lot of echoes will come back with like a grade 1 diastolic dysfunction. I call it like a grade 1 diastolic dysfunction. And there's a lab value that we can use in the heart failure setting, if anyone knows what that is. That's called BNP. So that's brain natriuretic peptide. As the atria stretch, they release a natriuretic hormone, it's a hormone, to literally cause diuresis, to get fluid off. So this really helps us in trauma because a lot of our patients, especially our geriatric hip fracture patients, they end up getting over-resuscitated. So they come in with a normal BNP, say it's like 100. And then all of a sudden on post-op day 1 or 2, their brain natriuretic peptide is like 2,000. And they go into new onset atrial fibrillation because of the stretching from the over-resuscitation or the massive amount of crystalloid product that they got in the operating room. So using this as a tool to diurese these patients is super important, or patients that have undergone an MTP. Also works out really well in that particular situation. So the most common cause of heart failure is going to be, number one, is going to be ischemia, right? That's the most common way you're going to die, is from an MI. The ischemia then is causing chronic heart failure. There's a magnitude or multitude of other different causes of heart failure, valvular disease, autoimmune diseases, infectious reasons. Maybe some of our cardiology colleagues can help us out in outlining all of that. But we're going to treat them with medications. They're going to go on like an ACE inhibitor or a beta blocker or all these different types of meds. And eventually, if their heart failure is bad enough, the end of the line would be a heart transplant, right? Especially in a young patient. They would need heart transplantation. So let's work our way backwards from that, because people asked me about LVADs, which I don't deal with at my facility. I did somewhere else, but that's a left ventricular assist device. So if someone comes in acute heart failure, there is a thing we can do to help improve that. So there's aortic balloon pumps. I don't know if those truly classify as LVADs, but you can put someone on an aortic balloon pump or an Impella device. And then obviously before all that, we would put them on vasopressors. And the common one in heart failure is going to be dobutamine, and then milrinone is another one. And patients also can be on a chronic infusion of milrinone as well, as a bridge to either a left ventricular assist device, and again, help me, cardiology people, if an LVAD, if an aortic balloon pump or an Impella count as an LVAD, or if we're talking true like left ventricular assist devices that are implanted. And all of that would be a bridge to heart transplantation, like we said.